All right, recording is started apparently. I probably shouldn't have done that early. Maybe.
Okay. Okay. Well, yeah. So hey everybody, welcome back to semester 2. We hope you had a good break. We certainly did. This semester is going to look a little bit different because now you're starting a bit more real medicine that's a bit more clinically orientated. And to account for this, we're kind of separating our notes system-based. So this week we're doing the upper limb, which is what you'll be starting. And we're going to start with the anatomy, focusing on that, and then proceed to other aspects of the upper limb. What I have done is there's a 3D software that allows you to kind of interactively use the upper limb. I've made kind of a practice video. Hey Ella, yeah, we do. So she asked if our slides available. We'll publish slides as soon as this is finished. So I've made this 3D technique, like this 3D video. I'll post it, and if that is liked, then I'll continue making them. If it's not, then we'll keep doing these slides, but it might be a bit more interactive. So we'll see how that goes.
Actually, David.
Yes.
Do you mind posting the slides now? Just because I feel like there's a lot of stuff that I'll try to rush through, and they might want to kind of go back. And I guess if they get their hands on the slides, they could kind of like at least maybe star it or something like that, so they can come back to it later on.
Yeah, that sounds good. We've got a lot of slides today, so we might rush through some things so you're not here forever. So I'll give you the slides now. Throw it over to Peter.
All right, hello guys. Hope you guys had a nice break, as David said. Obviously, school hasn't started yet last day, but it's a pretty good idea to start going and getting ready, just because anatomy is one of those subjects where you have to practice early on to get better as you go on. So like you have to know what's happening before you get into classes and shoots, or else you'll be pretty lost. That's what I found out the hard way. And you do anatomy throughout your year levels now ever since this semester. So you probably need to have an idea on how you want to study it. Yeah, so this is just the U system that we've always been using. Use that for your reference. Okay, so anatomy. Just before we get into the upper limb stuff, just a couple of introductions. Just to create the slides, major thanks to previous PSPs. Teach Me Anatomy, Ken Hart, they are perfect and wonderful websites. Images that I took from Google. More and Telly's textbook. It's a very good textbook. If you need the link, it should be on the Moomis Academic Drive, so you can look up there or buy yourself a hard copy if you fancy. And yeah, obviously the lectures. So what is anatomy? Well, anatomy is obviously a lot of stuff, but it's the body. And in Monash, you learn it in systems. So you learn 4 different systems in semester 2, upper limb, lower limb, back, and then thorax. Actually thorax / cardio, I think, but I'm not 100% sure. Now, what will you need to know? Well, there's a lot of things you need to know, but I wrote down the main ones for now. Bones, you need to know that, the joints, the muscles, neurovasculature organs, and the clinical pathologies related to these anatomy and anatomical spaces, things like that. As I said, there's a lot of stuff that you need to know. This is just not it. And it's not like knowing this only will help you get through it all. Like this is more of a base starting point. So if you know all of that, you're in a good starting point, and you need to kind of link it all together. And you definitely have to memorize a lot as well. So these slides that David said, there's a lot of them. I wrote all the notes that I had and all the notes I think you guys need to copy, except some, just because I realized at the end and I did not have any notes on it. So I'm going to try and cover the main points, at least in my opinion, because you guys haven't actually looked at any lectures, or if you have, good, but you just haven't done too much of it. So it's probably more important for me to go through the main points and let you guys read through the slides in your own time, because I have put them all there. Okay. And if you have any questions, feel free to ask any of them, PSP member. All right. So just an introduction, how anatomy will look like in general. So there's going to be, other than your lectures, 2 sessions in a week where you'll be doing anatomy, and they consist of technically 4, but I realize it's actually 5 now because dissection is back. It used to be gone during the coronavirus thing, and I realized you kind of came back after. So yeah, it's back. I haven't done it yet. We're doing it this year, this semester as well. So I won't be able to give you too much detail on what that is, but it's kind of cutting up people and realizing what it is, I guess, in the body. But other than that, there's 4 different ones. Tutorials, which is you get learning objectives and you basically make slides within your groups and then you present them to your peers. You're getting like randomly assigned to different groups. And you get imaging, which is just reading and interpreting X-ray, CT scans, sometimes MRIs, but those are not that relevant in year 1. And then you have series of questions to answer. Specimens, if you are unsure or you can go to campus, you'll be able to actually see the preserved specimens in real life in the anatomy labs, and there'll be questions there for you to do as well. If not, it'll just be specimen pictures, and you'll do them either on Zoom or on your own time on Moodle. And then there's Packer, which is basically a Kahoot session, and you just get asked a bunch of questions, some revisions, some about that week, and don't worry too much if you fail Packer. I've failed it many times, but if you do want to ace it, you definitely need to be on top of your game for you to really understand what's happening. Last point, and a very sad point, is that lectures aren't that really good. Some of them are really good. I find that the most people I talk to, they say that anatomy lectures weren't that great. So you need to really try and use different sources to really grasp what's happening, especially if you're learning online. So some resources and websites that I personally found and some of the other peers found helpful. Textbooks, there's a lot of textbooks out there. I think the 2 main ones, Gray's and Moore's. I personally use Clinically Oriented Anatomy, which is by Moore and Talley. Oh, that's an and, not an ABD. That's on the right, that's the 8th edition. That's pretty good because if you look through it, it tells you the anatomy, and then there's sections about the clinically related anatomy or clinical relevance. And that's really important for your ICL and just in general, because it actually links the anatomy to basically a course, which is medicine, right? To your patients and what problems can rise in patients. Also flashcards, and you can make your own, obviously like Anki and stuff, or you can download previous Ankis that other people have made. But there's also this thing, which is like, oh, not great, it should be better, sorry. I'm not quite sure if you can see my screen, but if you can, as in my video, there's this thing right here, and it's basically like flashcards of like your skull, and then it tells you at the back and stuff like that. It's pretty useful. It has a lot of great images. It's not real life images, it's images made by a guy called Netta, a very fantastic person. And yeah, I just find this useful sometimes, just looking at it, looking at the structures. It tells you the clinical relevance at the back as well. So that's also very important, but that does cost a lot of money. So it depends on how much you want to spend, I guess. Websites. Now, this is a very, very useful website right here, teachmeanatomy.info. I use this for my ICL every time. It tells you a lot of different things. Great, great, great resource. KenHub as well is a very good site. Now, PSPs. I personally used a lot of PSPs last year going through anatomy, especially when I couldn't understand the lectures or if I needed more information on it. So rely on them. Now, you can obviously use ours, use other PSPs this year, use previous PSPs. They're fantastic. And YouTube, also very great. Sometimes, especially if you're not getting it on hand, you won't be able to picture the anatomy in a 2D space. It's really hard. But on YouTube, there's a lot of great videos, either with imaging or with actual skeletons, whatever the case is. They tell you how and what the anatomy is doing. So that's really good. Now, this guy right here, Armando, I can't say his last name, has great visuals and explanations and for clinical anatomy. If you guys ever need to search a video on explaining certain systems or certain things, try to use his name in the search and see if you can get a good video, because he's really good. And also 3D anatomy apps. I think you got Anatomy Media and other apps on your tablet, on your phone, on your PC that allow you to see a 3D image. That's really, really good. Helps a lot. Okay, now we're going to get into the basics of anatomy language. I am not going to skip any of these basics because this is really, really, really important. Like, if you don't know this, you're not going to understand what's happening in anatomy. This is like the language of anatomy. So if you don't know what they're using, you won't be able to understand anything. Okay, so anatomy uses certain languages to describe where and which parts of the body they are referring to. You know that chat. Yeah, yes. Anatomical position, the position of reference in anatomy. So that's what we have here on the right. Okay, that's what we have as the anatomical position. So when we're normally referring to anatomical bodies, we refer to them within this position. Okay, so the palms are faced up or facing towards the front. So again, all anatomical descriptions take reference from the same position so that nothing is ambiguous, right? That's why we have a set position because, you know, for example, if the palms are down, that could completely change the language you have to use. So this is pretty straightforward. Hands, eyes, and toes to the front with your palms facing front as well. Arms adjacent to the side, not up, not down, and not like a crossover. Legs together with feet parallel. And then there's two positions we normally talk about. Supine, which is lying down, back against the floor, and prone position, which is lying down, but face and chest against the floor. Okay, that's two different types there. And now this is where some of the language really comes in. So the superior, inferior, and this is relatively easy, as the name suggests. One's above, one's below, and this is it. All of them is in relation to position. So the heart is superior to the stomach, right? The heart is over here, and the stomach's over here, right? So obviously the heart is superior to the stomach. Now, if I was to say the other way, I would say the stomach is inferior to the heart. So again, this is all these languages that you have to learn, because if you don't know what you really know, you won't be able to understand what's happening. Yeah. Cranial caudal is just a very common term, and this is kind of used more in, I think, X-rays, but it could just be in general. And the cranium is a medical term for skull. Cauda is for tail, Latin for tail. So that explains why cranial is above and caudal is below. I think this is actually used more in embryology, sorry. Yes, so that's very useful. Proximal and distal. So proximal is closer to, and distal is further from the point of attachment of the limb. Okay, so like if you look over here, proximal is over this side and distal is over this side. Again, this would depend on what structures you're indicating. But if I was to talk about this side, if I said there's something here, then this body part is proximal. So this body part in general is proximal to the body, and distal is going away from the body. Yes, anterior, posterior, very, very important to know the basics. Anterior is the front, so the front of the body, so like over here, like your face and stuff, when again in your anatomical position. And posterior is the back, so you could say the chest is anterior to the spinal cord, or you could say the spinal cord is posterior to the chest. Okay, ventral and dorsal, this is used a lot as well. Other terms you can use kind of similar in this orientation is palmar and dorsal, or plantar and dorsal. And palmar and dorsal is for hand, so only describing the hand. And plantar and dorsal is when you're describing the surface of the foot. And this is something that one of my friends, Leon, did. Fish have dorsal and pectoral fins. Dorsal fins are on their back. Pectoralis majus is the biggest muscle of the human breast at front. That's just one little thing you could know. But yeah, so that's one way he found it useful to understand. Yeah, you can find other ways to memorize this, but it's very important that you definitely know the differences, because you will be seeing these terms a lot. So again, ventral is front, by the way, and dorsal is at the back. Yeah, okay. Okay, yeah. Okay, medial and lateral. So medial and lateral is a very common term used as well. Medial is closer to the midline of the body. So if we were to think about the body having a midline drawn through straight down, so from superior to inferior, or whatever you want to kind of say, I guess. Medial is closer to the body and lateral is further away from the midline. Okay, so for example, if I was to be in the anatomical position, the thumb is lateral to the pinky, because pinky is closer. Well, sorry, the thumb is away from the body in relation to the pinky. Okay, so medial is closer, lateral is further away from the midline. Again, that's why anatomical position is very important, because if I was to have my palms down or palms facing the other way, then the thumb is technically proximal to the pinky. But as we know, we always have to reference it as if it's in the anatomical position. Okay, superficial and deep. That's basically very similar. Sorry, not similar. Opposite terms. So superficial is when you're kind of above the surface. Deep is kind of when you're down the surface, kind of, so closer to or further away from the skin surface. Okay. Now, these are the terms of movement. This is very important. So we'll get into it. Flexion and extension. So because these are anatomical terms for movement, it's normally when at points of joints in our body. So like your hands, your elbow joint, and your shoulder joint, things like that. So flexion and extension. So this thing actually kind of gets some people at the start. So flexion is bending or decreasing the angle. So I said that this occurs at the joints, right? So if you think about it, it's like the joint is like, if you flex, you're bending or decreasing the angle. Okay, that doesn't kind of make sense, but I'll explain it. And then extension is straightening or increasing the angle between the bones of the body parts. So for example, going forward in this case is flexion and going back is extension. And then going forward in terms of the hip joint is going flexion and the extension is going backwards. So you might be thinking, oh, isn't that just a general rule then? Like, you go forward with flexion and you go back with extension. Not really, because you can look at it over here when you talk about this part of the body, when you're only raising basically your half your leg, the calf basically. Now this is flexion because, as you said, flexion is bending or decreasing the angle. So if you think about it, the angle is here. The angle is being decreased when you're flexing. Okay, but that is really the only exception. The general rule is that you go forward with flexion if you really want to memorize it like that. But I think these are one of those things that it will come a bit more natural as you see and do anatomy. But yeah, so flexion is like that. Same thing here, extension, flexion, flexion, extension. Again, normally bending kind of indicates flexion. Like, how you say you flex your muscles and your biceps, right? Like, to do that, you do this, right? That's how I used to memorize at the start. But then I realized that there is an exception, which is your, I can't remember this joint, but anyway, yes, that leg over here, okay? And then there's other terms, supination and pronation. These are unique to the hand. If you can see here, supination is when you have your hand palm facing up. So you turn your arm, so I'm not sure you can see, but turn your arm so you can see your hand facing up. Pronation is going back. So putting your palm facing down to the ground. Okay, so that's supination and pronation. Opposition and reposition are unique to your fingers. Opposition is just basically when your thumb touches either your little finger or just basically any finger, I think, but yeah, normally your little finger. And reposition is going back, so not touching anything.
Peter, just a couple of questions that
Oh, yes, sorry. Yeah.
So one person asked, what's the angle we look at? So I think that you were referencing to the angle the bones make to each other. So do you want to take that one maybe? But
yeah, I'll be honest, that angle thing is what Leon makes, so I am not 100% sure either.
Yeah, I don't really like that one, to be honest.
Yeah. So yeah, sorry, I couldn't explain it because that explanation isn't by me. So yeah, so the way I memorized it was like forward is flexion. No question, this will happen with David, but forward is flexion for most things, back is extension for most things, is that basically this part here.
Yeah, but ultimately it's pretty arbitrary because so Sophie asked when something's flexed, others extend. So that's true. So when any movement of a muscle, there's an agonist and an antagonist. So if you're moving your biceps over here, you have your biceps brachii as the agonist and your triceps are relaxing or extending. So for most muscle movements, something is flexing and something is relaxing or extending to support that movement. So it's better off just remembering extension is when I move my arms forwards. Extension is when I move it back, like when I'm marching, with the exception of the knee joint, where you can see that angle is. But also, like, extension is commonly more unnatural. So flexion is common things that you do that isn't. So there's eccentric motion of the muscle, which means the muscle is stretching. That's what extension is when you're stretching your muscles. And often that's uncomfortable because you don't want to stretch your muscles. It's better to contract your muscles, and that would feel more comfortable.
Yeah, it's uncomfortable, and a lot of them have less degree of like whatever you want to call it, like flexion. If you think about it, you can put your arm pretty up high, but if you try to do that on the back, it's pretty impossible to do without even doing a bit higher than 90 degrees. I think 65 degrees is what they always say. So like if you think about it that way, that's really good as well. Okay.
Yeah, and there's a concept called tone. And tone is an important clinical concept, which is important to what Sophie said, in which tone is the opposing force between the agonist, or the muscles in this case that want to do flexion, and the antagonist, and the muscles that want to do extension. And in some people, the agonist might predominate, and that might mean their arm is more flexed than usual. So they could be hypertonic. So that's a concept. The concept of tone is these muscles are constantly contracting and opposing each other, and often that cancels each other out, which is why you can have steadiness. Whereas in diseases like Parkinson's, that affects that ability, and you have hypertonia. It's a good question. So, does that help?
Yeah, hopefully that helps. That will be covered, by the way. The tone and stuff will be covered in physiology this semester. So, I think, right? Or they already covered it? Yeah. So. Don't worry too much if you don't understand what happened. You'll learn it. Okay, so, and also just one thing, in relation to like how we talked about antagonists and agonists, like biceps, triceps, a lot of that movement and stuff will help as you learn the anatomy of it. Like if you realize where it inserts and where it originates, it will make more sense when I say it a bit later. I will reinforce it later, but it's very important because if you know that the biceps are over here, attaching from here to here, when they contract, they're going to do this. Triceps to go at the back, so they do the opposite. So things like that will help you learn anatomy. Okay. All right. So continuing on, abduction and adduction. So obviously, you don't actually say that. You say abduction and adduction, but you'll see a lot of lecturers using the term AB and adduction just because they want to be clear of which one they're referring to, because they are very similar in pronunciation, especially on Zoom. So abduction is the movement of a limb away or towards, sorry, no. Okay, yeah, so, I'm not quite sure about the towards the midline of the body, but abduction is basically when you move the limb away from the body, and adduction is when you move something towards the body. Oh, okay, so towards the midline body is the adduction. Okay, got you. Yeah, so adduction, like add, that's how I used to like add it to the side, I guess. That's how I used to memorize it. So that's adduction going towards the body, abduction going away. That applies up here as well, and also applies to fingers as well. Medial lateral rotation. So medial is moving anterior surface of a limb to face or face.
Adduction. Yeah.
Moving anterior surface of a limb to face is medial, and facing away from the midline of the body is lateral rotation. Because medial, it's obviously closer to the body, towards the midline of the body. If you rotate medially, it means you facing it in, if that kind of makes sense, towards the midline of the body. Whereas lateral is laterally rotating, so laterally rotating out, so it naturally faces the outside. Circumduction is swinging a limb around. It's like this. It's a compound movement. Okay. So ankle, there's dorsiflexion and plantar flexion. This is a movement unique to the foot.
Yeah. Just go back a slide. We've got a question.
Oh, sure. Sorry.
So the question is, so is medial and internal rotation identical? They are not identical. So medial rotation is when you rotate medially, which means towards the midline. Lateral rotation is where you turn away from them. So if I'm going to stand up like this.
We're doing whips. He killed his cousin.
Yeah, like this.
Silenter.
Rotation is towards my body.
Yeah.
Same as abduction is away from my body. Adduction is towards my body. Sorry, it's inverted on the camera, and I'm very uncoordinated. But I think it's not that hard to remember. It's toward, reference point is the midline, abduction is away from midline, adduction is towards midline, medial rotation is towards the midline, lateral rotation is away from the midline.
Yeah. So yeah, I'm not quite sure if these images help, but if you can just see the limb moving in that like rotating in that direction, that's medial direct. But if you were to rotate that limb like how it is in this, I guess, purple line, you'll face the anterior part midline if for some reason you can get it all the way to the midline. Okay, so that's medial rotation. Lateral rotation, the outside, going out way. Yes, okay. So the ankle movements, dorsiflexion and plantarflexion. This is unique to foot, and as you can see in the images, dorsiflexion is when you go up, and plantarflexion when you go down. Yes, and inversion is also unique to the foot. I mean, they normally use it for the foot. I'm not quite sure if it's only for the foot. Inversion is when you like invert your thing. So like now invert is like introvert, or it's like inside. So you're bending it inside towards your body. Eversion is like when you bend outside. So obviously inversion ankle sprain or injuries are more common. If you've ever done an ankle sprain, you'll realize your ankle tends to go in, and that'll be covered later in the lower limb, what ligaments are damaged. But yes, that's inversion, eversion and inversion. Other ones, lateral bending of the back. So this is just other pictures, and lateral bending of the back can also be known as this term called ipsilateral or one-sided flexion. So that's just another thing they use. And this is one thing that kind of comes into importance, chest x-rays. So when you're taking chest x-rays, it's also known as CXRs. We have a patient protract their scapula, the shoulder blade, and have the x-ray source shining at them from behind whenever possible. And this will be known as posterior anterior view or PA view. And we'll go through that in the next slides. Other important ones are this planes. So sometimes we refer to planes and anatomy. So kind of like maybe if you were to cut in that way or things like that. So there's a median plane. So it's like the midline, sometimes known as the median sagittal plane. So like median plane. And then there's the sagittal plane. So this is the more common term used. And that's when any plane parallel to the median plane. So it could be here, but it can also be like closer to the arm, closer to the fingers, or closer to the midline, things like that. But again, it's kind of like cutting the person so he has only like one leg, basically, like cutting the person in half through the midline. Coronal or frontal plane is as pictured. So it's like coronal. I think one of the lecturers said like it's like a crown, something along those lines. It's like you put the crown at the top of your head and splits it. I don't really know, but yes, I just memorized it, to be honest. An axial plane is transverse, or you can also call it transverse. And you think about an axe cutting down a tree, and then you gotta go this way. So therefore, it's axial plane.
Peter, a couple of questions.
Oh yeah, sorry, I didn't see that.
Can you just go back a slide for a second? So just with these views, if you take a sagittal plane, that means when you look at the body, you look at a cross section of this area. If you take a coronal plane, you look at a cross section of this part. And axial, you're going to have, if this is you've sliced the wrist in half, you've sliced the wrist and you're looking at it like that. We had questions about supine and procline, so the lying down. Can we go back to those slides, the lying down?
Oh yeah,
slide,
sure.
please?
I think that was
That's
the
quite
start.
important.
Yes.
Yeah, I think that was towards the start.
Yep.
So supine essentially means, imagine you're in bed. Supine means lying down on your bed, completely flat. You're looking up and your wrists are out, like in this position. They're lying on a bed. In a prone position is when you've turned over, your head and your groin and everything is facing towards the bed, and the person is lying down with their head down. So it's essentially lying, that's the difference. Does that make sense? Okay, wonderful. And wait, no, does that make sense? Okay, great. And the second question was the lateral bending of the back, ipsilateral flexion. So it's quite confusing because the back, different people use different terminology. Essentially, flexion means that you just use the word flexion. Ipsilateral means to the same side. So it's a lateral bending. It's a flexion like this or flexion like that. Ipsilateral just means one side. It's to one side, which is evident because if you're flexing, you're going to go to one side. Yeah. So it's just bending like in this picture. That's lateral flexion. Does that make sense as well? Okay, wonderful. Any other questions? No. Let's keep going.
Yeah, keep these questions coming, guys, because this is the basics. You definitely need to know this pretty well for you to at least have any understanding. Yes, Sarah, these are some really lovely pictures, videos, GIFs, whatever they call them, from, I believe, PSB Papa from last year, sorry. Yeah, so if you ever get stuck, just literally just refer to this. It's pretty straightforward. It has all the things we basically talked about. This radial and ulnar deviation, it will make more sense when you learn the radius and ulnar bones. Yeah.
Yeah, can you go back a slide?
Oh yeah, sorry. All good.
And one more.
Oh,
So with this one, the external and internal rotation, that's kind of a different way to think about it that they've been limited to due to the schematic of this. It's more of a rotation of your actual rotation internally and an external rotation. They're talking about more clinical tests. So remember, internal rotation can also mean literally, yeah.
Yeah.
Oh,
So
supination is when you turn to show your palms. Pronation is when you turn to show the back of your palms.
yes.
For me, they're doing external rotation as rotating this joint.
Yeah.
Yeah,
Yeah, I think they use external internal for this type of movement.
yeah, you can do that too.
Yeah. Yeah, so I think there it is. Oh, pronation and supination that we were talking about, a reduction, flexion, all of those. Position touching your pinky with your thumb. And this is with your legs, flexion, extension, normally abduction, adduction, and flexion at your knee joint is going backwards. Inversion, eversion, plantar flexion, dorsiflexion, flexion of your back, extension of your back. All right, so with all of those terminologies in mind, let's move on to joints. So there's basically 3 classifications of joints that you'll learn in, at least in anatomy for now. I believe that's only 3, but there's synovial, fibrous, and cartilaginous. So synovials are united with joints are united with a joint capsule, which is composed of serous synovial membrane, and this joint cavity also contains the synovial fluid, which makes the synovial serous synovial membrane. And these joints are very freely movable typically. They're joints of locomotion, and they're the most common joint in the body. So you'll see this most. And like your elbow joint, all of those joints that come to mind when you say joint is actually synovial. And then there's fibrous and cartilaginous. Fibrous ones are united by fibrous tissue. And these movements of the joints depend on the length of the fibers. And they are typically joints that require strength. And then there's cartilaginous joints, which is united by hyaline cartilage or fibrocartilage. And normally they have little mobility and they only have slight bends in early life. Okay. One thing I didn't write on the lecture slides, but I wrote in the speaker notes, is the difference between tendons and ligaments. So tendons and ligaments, some people just mix them up at the start. Tendons connect muscles to bones, whereas ligaments connect bones to bones. So they are definitely different. They might look very similar, but they are definitely different because they attach different things to the bone. So,
Okay, can I interrupt you for a second?
Yeah, go.
So someone asked about thumb movements. Do you mind if I share screen?
Stop.
So let me just show you thumb movements because these are an exception and they're particularly more difficult. So if you don't get it right away, that's okay. With the thumb movement, abduction is abduction is when you go 90 degrees to the plane of the fingers. Adduction is when you go back. Flexion is when you go inside. Extension is when you go outside. Because the thumb, as we're going to talk about in a second, is a condyloid joint. It can go in all these directions. So it can go in more directions. Abduction is 90 degrees to the plane. Adduction is back. Flexion inwards, extension outwards. Yep. And the tendon and ligament, I could never remember that. So that's a good one to get early.
Yeah. So it definitely tricks a lot of people. So, yeah. Tendons to muscle bone, ligaments bone to bone. Okay, so as David was mentioning, these are some of the synovial joints. There's 6 plane joints. These have gliding or sliding movements. They have like the recurrent flap surfaces. So if you look over here, this uniaxial thing is just kind of referring to the axes. I'm not quite sure if you have to know that as well, but maybe you do. Yeah, maybe David says no, so you don't have to worry about that. This you can see a joint of plane joint in the acromioclavicular joint, which we'll go through today. Yeah, so you can see here, this is how the joint moves. So it goes around like in this. And then there's the hinge, which allows for flexion or extension. So it has one plane. Oh, so I just realized that explanation is all gone. Sorry.
Working hard or hard or working?
Working hard. These guys are not that great at explanations. That's okay.
Okay, sorry for not being great. Try our best. Oh, wait. These are hinge points, so they allow for flexion and extension, one plane. As you can see this image, this is how it works. So this is like an elbow joint, for example. It goes for flexion and extension. And then there's a saddle, which is over here. It allows for abduction, adduction, and they have a concave, convex surfaces. And it basically has a saddle-shaped head, and they permit movement in two different planes, like this. And then there's a condyloid, as David was talking about, is flexion, extension, abduction, and adduction. They allow for all of them. And as you can see in here, they allow for circumduction as well, which I didn't write down. That's like in our metacarpal carpophalangeal joint, which we'll learn about when you do the hand. And then there's a ball and socket, which is flexion, extension, abduction, adduction, medial, lateral rotation, circumduction. So multi-axis has a lot. So this is probably one of the ones that you can do any type of movement with, and that's like hip joint. Then there's the pivot joint, which only rotates around the central axis. So like it basically just kind of rotates around this part. So it doesn't actually do any of this flexion and extension kind of stuff. And that's at these atlantoaxial joint, which you also learned this semester. Okay, so last thing before we go into upper lip is imaging introduction. So this is just some real quick things. X-rays, don't really need to know exactly how it works, to be honest, as long as you know how to take them or how it works in terms of which one what type of image you get. So there's 3 different views. There's AP view, which is the beam goes posterior to anterior, because basically an X-ray shoots a beam towards the detector and you get an image. So if you shoot the beam with the person hitting the person's anterior surface hitting first, then the posterior second, then you have an AP view. Then if you hit the posterior part first, then go to the anterior part of the person, then you get a PA view. And then if you do it to the side, you get a lateral view. That's really important because sometimes you might need to understand that different views have different characteristics showing up. In real life, they do tell you which part or which view it is, because it is pretty hard to find out. But and I believe in the exams they'll also tell you. I think that's what they said, for at least for us. They said the exams they'll tell you AP or PA view. But during the imaging shoots, they might ask you to see which one's AP, which one's PA. On the actual X-ray film, you will see that they'll have white parts and a darker part or black parts. And basically whitest represents the least radio dense. So radio dense is like the degree of passage for the photons. So basically, if it's least radio dense, it means that basically all of it passed through. Okay, that's why it's most radiolucent. Then there's fat, water, and most tissue, spongy bone, and compact bone. So it's in that order. As you go down, it's black. So for example, something like metal, if someone solders something that's metal, it will be shown as black on the X-ray. Yes, yeah, no, that should be the other way around, sorry. I don't know why I wrote whitest there, I just realized. Okay, yeah, it should be the other way around, sorry. So this is a better image. As you can see, this is a metal, therefore it's white, and the outside stuff is black because that's air. So yeah, sorry about that. I don't know why I wrote it the other way, but yes, I think David was probably correcting me. Visual difference between AP and PA, please. Okay, so I think one of the major ones for difference between AP and PA views, I'm assuming you're talking about the X-ray film itself, is like the ribs. So it kind of makes more sense when you learn the anatomy of the ribs, but like the ribs kind of look a bit more like the front part looks a bit more like in front. It might sound really weird, but it looks more in front when you look at an AP view, whereas in the PA view, it looks like it's at the back. But as I said, it is pretty hard to determine which one's which, and most people get it wrong. So don't worry too much about it. It's not that important to know, really.
It also changes the scale. So
Yeah, scale as well. The heart gets enlarged.
if the heart gets enlarged, it can be diagnosed as a condition. Yeah. Yeah.
Yeah, but again, it's not that important to really know.
Yeah.
CT scans, these produce a cross-sectional image. They take a 360-degree scans. They have the same radio density as X-rays, basically. There's different views. So again, it's reset the format. So we have exoplane. This is the most common.
So 1 second, Peter.
Yeah.
Daniel asked a question. He said, "Is one view better?" So usually people do PA views. They're the most common type of view that people do. They reveal the most amount of information and everything is in scale. But obviously, if someone's in acute pain, you can't get them to stand up and turn around. So then sometimes they'll do AP views in emergency situations.
Yeah, so it would depend on the situation, but as you said, mostly PA. CT scans, exoplane. The image is shown as if you are standing at the patient's feet and you're looking up. Therefore, your right is the patient's left. So this part here, I'm not sure if you can see my cursor, but this part here is the left side when we're looking. Therefore, it's the right side of the patient. Yeah, because we're looking like it's our left, but it's their right because we're looking from the feet looking up. Sagittal plane is the image shown as if you are standing in the patient's left and progressively seeing through them. So basically like a lateral view in terms of an X-ray. And then there's the coronal plane, which we talked about before. And this image is shown as if you're standing in front of the patient, right? So you kind of get like the coronal plane view. MRIs, you only really need to know what they are, to be honest. They're not asked that much. It's kind of like extra questions if you finish early at imaging sometimes. But one thing that the previous PSPs did write about is T1 and T2 weighted images. And basically just T1 has fats only and they're bright on MRIs, whereas T2 images have fat and water and they're bright on MRIs. So the way to memorize is T2 has the 2 in the H2O, therefore it includes the water. But other than that, it's not that important. All right, so a little quick quiz before we move on. What movement is this? Type in the chat, send a direct message.
Yeah, good. We've got a couple of answers. We'll try
A
to get
couple,
them.
okay. Yeah, so
everyone got it right. Good job.
good job. Yeah, pronation. As you put your hand or your palm down, okay? Supination would be the opposite. Okay, so next quiz. The red body part is blood to the blue body part. So this is talking about.
Yeah, we'll get a few more. Yeah, good job. So everyone got a few answers.
Yeah.
Everyone got it right.
Okay, yeah, so it's very simple, straightforward. Again, these quizzes are just really simple because this is your first time probably looking at it, or maybe a second or third time around. Just wanted to make sure that you understood the big picture. Okay, upper limb. So I'm going to really quickly go through this. Shoulder, arm, and bone. Shoulder and arm, bones. So there's a lot of bones you have to memorize. Oh, one thing here, quickly before we go into it. So how to approach anatomy, or at least MSK anatomy. And this is from PSP Pingu that I used last year. So you definitely have to get used to the anatomy basics, which is what we just went through. So you really need to know that. And then you should learn the bones. I mean, you don't have to learn in this order. It helped me. You learn the bones, and then you learn the muscles in relation to where the compartments are. So where the muscles are, which type of compartment there are, and hence what type of actions they do. And you can relate that to the bones because they will attach to some bones. You can learn where the bones are in relation, and they'll help you also learn the action as well. Also learn the nerves. That'll be the brachial plexus in the upper limb, which supply the muscles and the exceptions. Okay, because they will definitely ask you a question about the exceptions. Learn the joints, so the ligaments and the stuff relating to the joints. Learn the arteries and veins. That's the shorthands I use. Learn the spaces. There's a lot of spaces out there, and they're really clinically important. So they will ask you a lot of clinical relevant questions there. And yes, in the end, learn the clinically relevant stuff. Like, for example, what happens when this nerve is damaged, and then what happens when this space is compressed, what happens when this muscle contracts. All right, so what do I mean by exceptions? Okay, so there's like a general rule for a lot of nerves, like they do certain things or they supply the anterior compartment or things like that, except, and then they'll actually turn out to also supply some part else. Like, yeah, if that kind of makes sense. It will make more sense when you actually learn them. But my main point here was that learn the general gist of what they do, but also learn the exceptions because they will definitely ask you questions on it.
Yeah. And space isn't necessarily an empty space. The space can be like your elbow is a space, or your shoulder, it can be a space. So space is referred to areas that are kind of quite clinically charged.
There's also other approaches. So anatomy is a lot about relationships. It is definitely a lot of memorization for sure, but it really does help if you understand it all together and intertwine all of the relationships together. So it's really helpful to read a chapter with all the context of the relevant system, and this will help relate the structures to each other. Okay, and also anatomy is also like languages. So that should be you want to immerse yourself in all the terms and read about how they relate to each other, and this will help memorize as well.
So we asked our anatomy tutors last year how to learn it, and they essentially said everyone was doing like Anki and Teach Me Anatomy, doing sections and all these mnemonics and stuff. They essentially said the best way to learn it is to read a chapter about it because you have to understand everything in context. So that's quite time consuming, but that's kind of faculties, is to get the Moran Daly's book online or however you can get it, read a chapter, and you'll understand everything in relationship to each other.
So it is true, anatomy is a lot of memorization, but just memorizing without relating them to each other will not be good for you. It will take a lot of time as well. Okay,
And
so these are some. Yeah.
Questions on exams are mostly about relationships of things.
Yes, very true, very true. Shorthands. These are some of the shorthands I use. Refer to it later if you need. And this is just an overview of just some of the bones.
Yeah, I can go through that if you like.
Yeah, you can, yes.
So the body is essentially broken up into two sort of systems, and these are useful in describing different systems of the body. So when talking about the musculoskeletal system, there are two principal divisions. The first is the axial skeleton, which consists of the cranium and skull, the ribs, sternum, vertebrae, sacrum, kind of the midline structures. And that is involved in kind of anchoring the body and transmitting the weight down to the base sacrum. The appendicular skeleton is divided into two sections. There's a superior appendicular skeleton, which is what we'll be talking about today. That consists primarily of the scapula, the humerus, that sort of upper limb bony structures. The inferior appendicular skeleton is essentially what is discussed in the lower limb, includes the pelvic girdle, thigh, leg, and foot. So these are some divisions to put this in context.
Yeah, okay, so we spent a lot of time, so I'll try to speed through the main points. So these are some of the bones to learn in the upper limb that you'll do. We won't go through all of them, we'll go through the clavicle, scapula, and humerus today. So shoulder joint. So the shoulder joint is made by three bones, clavicle, scapula, humerus, and they actually have three different joints within them. The glenohumeral joint, or also known as the rotator cuff joint, is the glenofossa of the scapula and the humerus articulating together. Acromioclavicular joint is the acromion process of the scapula and the clavicle articulating together. And the sternoclavicular joint is the sternum and the clavicle. As you can see, the name of the joint is pretty straightforward in terms of the structures that it's related to, and that's a lot of anatomy stuff in general. This is why you need to make sure that you are trying to relate everything to each other. Yes, so we will definitely go into them more in detail. So this is just one big slide that basically comes straight from my notes. Had most of the information that I found very useful throughout the lectures and the PSBs. I won't go through all of them, but just the main points. Glenohumeral joint is a ball and socket joint, therefore it's highly mobile but very unstable. Has these 3 ligaments. The main clinical relevance here is that the dislocations that occur in the glenohumeral joint is named after the direction of the head of the humerus, and the inferior is the weakest part. So because it's the ball and socket joint, it's highly mobile but unstable. I think you'll go into week 2 about how the stability of the glenohumeral joint or shoulder joint in general is stabilized. But yes, and bursa is present, and this is just a thing that helps reduce friction, and therefore it could also be inflamed, which will result in bursatitis, which results in shoulder pain. Acromioclavicular joint has an acromion process. We'll talk about that. It's a plain joint, and a dislocation of the AC joint will lead to shoulder separation. And the reason is because the coracoaclavicular ligament of the acromioclavicular joint basically holds up the entire arm. So if you were to dislocate the AC joint, which will mean you damage the ligaments, then the shoulder will basically separate because you're losing that one ligament that's basically holding up the entire arm. And the sternoclavicular joint, it's a saddle type synovial joint, but functions like a ball and socket. Okay, there's 3 ligaments like this. It's nicely color coded, and they are rarely dislocated. And if there is dislocation, anterior is more common. Okay, clavicle. So that's a bone you have to know. It's over here in relation to the rib cage and the scapula.
So I just orientate with that quickly.
Yeah, sure.
So Peter will go over this in more detail in a second, but just to get a gross understanding so you know what we're talking about. This structure here, you can't see my mouse. This structure here is called the sternum. The sternum has subdivisions. This is the body of the sternum. This is the xiphoid process of the sternum. This is the manubrium of the sternum. The manubrium of the sternum is the most important thing for you to understand right now. That's because the clavicle will attach to the manubrium of the sternum. Okay, at the sternoclavicular joint, clavicle, sternum. Over here on the other side towards the acromial end of the clavicle, it's going to attach to the acromion. The acromion follows the spine of the scapula. If you look posterior end, there'll be a spine that goes through, and it's the lateral protrusion of that spine of the scapula, and that is called the acromion. That creates the acromioclavicular joint. The glenoid fossa someone asked about, which is why I'm doing this. This is a glenoid cavity. It's a little indentation into the scapula on the lateral end. The humeral head will fit in this little hole over here into this fossa. A fossa is another word for like a hole, and that's where the that humeral joint will occur. So hopefully now you kind of have, now when we explain it, it might be a bit easier to give context. Sorry, Peter.
No, good. Okay, so now we'll go into describing the clavicle, so the bone itself. So as they mentioned, because it connects at that sternum manubrium, it connects the upper limb to the trunk. And the medial 2/3 is convex anteriorly, whereas the lateral 1/3 is concave anteriorly. So yes, yes. So if you look over here, this is the anterior and this is the posterior part. This is the inferior and superior surface. So you're looking from top, maybe from in terms of like from bird's eye view, and then from feet down looking up in the bottom image. These bone processes or landmarks, you will see later that a lot of muscles and tendons attached to it. So that's why it's all written over here. And the more important thing here is that the fact that the reason why we need to know that medial 2/3 and lateral 2/3 occur is because this is the point where it transitions from convex to concave, and hence more common for fractures, or it's a common location for fracture. Okay, so clinically very relevant, and it articulates with the sternal end. The sternal end articulates to attach to the manubrium of the sternum at the sternoclavicular joint. And then the acromial end articulates with the acromion of the scapula at the acromioclavicular joint. So over here, it joins with the sternum. Over here, it joins with the scapula, with the acromion process. It's frequently fractured in children, and the common injury is fall on outstretched hand or whoosh, which is a very common word that they used. Yep.
It's just a question. So it says, in the lecture, they talked about how glenohumeral is atypical because it has fibrocartilage instead of hyaline cartilage. What is the benefit of having fibrocartilage instead? So I think the point is not that it has fibrocartilage instead of hyaline cartilage. The glenohumeral joint has hyaline cartilage as well. Hyaline cartilage is quite hydrated, which allows for the mobility. When they say fibrocartilage, I think they're talking about something called the glenoid labrum. The glenoid labrum is this fibrous indentation on the glenoid fossa. Can we go back one slide? Sorry, Peter.
Sure.
There is fiber sticking out here. The reason why you have fiber there is it is to deepen the joint to increase the stability. Because as they might have mentioned in the lecture as well, this is quite an unstable joint. And the reason it's unstable is to support further mobility. So you have some fibrocartilage that deepens it, as well as the normal hyaline cartilage that allows the joint to move. This is in contrast to the lower limb, where you have stability that is prioritized more than the mobility. And as a result, this fossa is much larger in the lower limb. Is that helpful?
Right, thank you. And yeah, so some clinical relevance is the thoracic outlet syndrome. So there's this thing called the thoracic outlet, which is a space between the collarbone and the first rib. And anatomists will refer this space as thoracic inlet because non-circulating substances like food or air could enter. But then clinicians will refer to this space as thoracic outlet because they want to emphasize the arteries and the T1 spinal nerves that emerge through the thorax, from the thorax through this space to the lower leg and the upper limb. And therefore, the syndrome of the thoracic outlet, or the thoracic outlet syndrome, is the obstruction to this space and hence the compression of the vasculature and the nerves in the thoracic outlet, which will lead to shoulder pain, neck pain, and finger numbness. Okay, so thoracic inlet and thoracic outlet is the same term, it's just that you would learn thoracic outlet more because of you're studying medicine. My next bone is scapula. It's at the back, and there's a lot of muscle attachments here. And the joints that occur with scapula we talked about is the acromioclavicular joint, the glenohumeral joint. We already went through that. And the fossa, which is very common word used here throughout anatomy, is just means shallow space. Humerus, it's the big arm bone, so it's like this one over here, if you can see my camera. Also has a lot of surface landmarks. And the joint it creates is the glenoid fossa. Oh no, glenoid fossa joint, glenohumeral joint with the glenoid fossa. And some of the important features, so I wrote down a table on the next slide of all the surface landmarks, but some of the most important ones, in my opinion, is the surgical neck, which is a common fracture, a cypher fracture. So if you can see in this image, where is it? Here it is. So that's a very common cypher fracture. And there's clinical relevance there because a lot of nerves and some nerves and arteries pass through. So if you cut that, it will damage the arterial supply. The greater tubercle, this is the point of attachment for all rotator cuff muscles, except the subscapularis. So this is one of those things where you should know the exception as well as the general thing there, which is that all rotator cuff muscles attach. Lesser tubercle is the attachment for subscapularis, and intertubercular solus or bicipital groove is where the long head of the biceps brachii can be palpated. All these muscles might not make sense, but you will make more sense when you learn them. So this is just a nice summary table from my notes. Yeah, there isn't anything that we haven't talked about that's not that important. So, but again, you can definitely look through it later. This is the What about, so this is the in relation to the humerus. Yeah, we talked about the surgical neck. The head of the humerus is what actually articulates with the glenoid cavity of the scapula or glenoid fossa. So keep that in mind. Yeah, we talked about that. Yeah, sorry, I'm trying to just make sure I'm pointing out the main important ones for you to know. Always come back to this slide when you need to refer to it. I believe that's all the information that at least I learned from last year. Okay, so a really quick quiz. Just really, again, some really simple ones just to understand, make sure that you guys pay attention. Shoot your answers.
Yeah, we got some. Any more? Yep. So remembering that the glenoid fossa is on the scapula and the humerus has the word humeral in it. Any more? Okay, we got a few.
Okay. Now, this glenoid humeral does not exist. I just wrote that there because you might have remembered that it's glenoid fossa that they articulate with, but the actual name is glenohumeral joint.
And just quickly, we go back
Yes.
one slide.
Yes.
So the reason why it's not the acromioclavicular joint is the acromion is over here. Like we said, it's a lateral extension of the spine of the scapula and it joins with the clavicle. Whereas we're talking about the humerus, which is down here on the scapula.
So now we'll just quickly move on to the muscles and movements. Now, I did write and on top of here that a lot of these are really low yield, especially memorizing all of the attachments. It's pretty useless. Okay, you just need to understand the big picture of which type of bone and area they're attached to, because that might help you with understanding how the muscle moves and what type of innervation they get. But really isn't important memorizing exactly all of the things I wrote here. But I did write it if you want to know for sure. This is the anterior exoappendicular muscles. This is how they call it in the textbooks. It's basically the pectoral muscles, pec muscles, whatever you want to call them. There's 4, pectoralis major and minor, and then the subclaviculis, clavillus, and serratus anterior. So this is a very important muscle because that's a very common buzzwordy question that they'll ask you a lot. And if you look at the images, it'll make much more sense. So over here, so there's different parts of the pectoralis major, but most importantly is knowing that it's a very big muscle and it's actually superficial to the pectoralis minor. So that's underneath. If you can see that, this is a very common thing that they use in anatomy images. You can see how it's cut. This happens in specimens as well. So this will indicate that this is deep to this muscle. So I think yeah. So, yeah.
Sorry, I'll just quickly interrupt. Just to these axioappendicular muscles, there's actually 17 of them. So they're the reason why there's not many fractures to the scapula, and you clearly don't need to know all 17. For some reason, the main one they talked about was the serratus anterior muscle. That's because it's quite important in sport physiology, because that's boxers often have a very well-developed serratus anterior muscle that's involved in protraction.
Yeah.
The main other muscles, like the pectoralis minor, they're actually more important in landmark division. So an artery that runs through here is named differently according to where it's positioned on the pectoralis minor. So as a muscle themselves, these are mainly for sport, people who do exercise rather than clinically.
So yes, that's very important point there. Yeah, and this is pectoralis minor, subclavillus. Again, clavicle, clavillus, very similar names. Probably indicates that something is to do with the muscle, to do with the clavicle. And this is serratus anterior over here. Yes, and this is just showing the attachments, which again, you don't need to know too much in detail, but definitely need to understand where they are. So subclaviculus, pectoralis major, serratus anterior on the ribs. This is how it looks like. Okay, so this is a very high yield one. So I actually had a separate slide for it. So serratus anterior is basically a broad sheet of thick muscle, and it looks like sawtooth. That's how you can indicate what type of muscle they are in specimens, especially. And these are some of the buzzwords. So mastectomy, winging of scapula, knife to the axilla. If you see any of these words in your question, that probably indicates something is wrong with the serratus anterior. Okay. So the winging of scapula occurs because serratus anterior is damaged. Mastectomy is a surgery to remove all breast tissue from the breast as a way to treat or prevent the breast cancer. So while doing that, you could also affect the serratus anterior as well. Yes, now the shoulder muscles. There's two different types, intrinsic and extrinsic. Intrinsic is also called scapulohumeral, and they basically all originate from the scapula and clavicle, and they insert on the humerus. So these are the 6 muscles: the deltoid muscles, the teres minor, major, and then the rotator cuff muscles, which has an acronym called SITS. So supraspinatus, infraspinatus, teres minor, subscapularis. Okay, so minor and major, make sure you don't get confused. The one in the rotator cuff muscles are minor. Extrinsic, they originate on the torso and they insert on the bones of the shoulder. Like honestly, if you note around to this point, you're in a pretty good position, okay, to know the general rule. Don't need to know exactly what type of bones of the shoulder and what type of the landmarks of the clavicle they insert from or to insert to. There's 2 different types, superficial and deep within the extrinsic. Superficial is trapezius and latissimus dorsi, and then there's deep, levator scapulae, rhomboid major and rhomboid minor. Yeah, okay. So extrinsic shoulder muscles, they are relatively low yield compared to the intrinsic muscles. Okay, so I'll quickly go through them. Again, we talked about the 5, technically rhomboid major and minor is 2. So did you want to say something, David?
Yeah, just wanted to point out, yeah, sometimes I'll talk about exceptions in Paco. There was a couple of questions on the innervation of the trapezius, which is by the accessory nerve, which I think is cranial nerve 11. So it's actually from nerves coming from the brain. You can see over here that the trapezius has quite, can be innervated from the brain. The rhomboids, minors, and majors are on the back here. Yeah, I think the rest, you have to recognize all these muscles. Latissimus dorsi attaches to the humerus, not actually to the scapula. So you have to visually know these muscles. I did know their innervation at the end. I think that if you have time, it's helpful to, because there's maybe 1 or 2 questions. But yeah, definitely know what they look like.
Yes.
Know this, the trapezius and these rhomboids.
So, like as we talked about before, like the fact that the trapezius is all the way to the skull may help you memorize one of the nerves that innervates is a cranial nerve. Right. So just things like that really help you understand anatomy in a big picture, instead of having to individually memorize everything on an Anki or anything like that. Well, I mean, Anki's wonderful, but just telling you don't spend so much time and so many cards making Anki, just memorizing it. Yes, so latissimus dorsi is a very common muscle, I think, especially at the start. And I just remember seeing a lot of latissimus dorsi questions and stuff like that. They insert like at the front and to the intercalated solus, which is also the bicipital groove, which is part of the humerus, if you remember from the previous slides. Okay, and the muscle actions really make more sense if you understand where they are. Kind of, I mean, for the intrinsic muscles, shoulder muscles, they're not that important. But just try and think about the insertion or origin, and think what would happen if they contract. So all muscles like basically get smaller when they're contracting, right? Just thinking about it really generally. So what would happen to the bones if that would happen? If that was to happen, it will make more sense if we talk about the intrinsic shoulder muscles here.
Yeah, and
so this is very. Oh yes, yes.
Sorry, someone just asked, do we need to know the exact muscle actions or just the general actions of the muscle? I think that you don't need to know more than the extent that if these muscles contract, there's going to be retraction because this is going to go inwards. If levator scapula, that's going to elevate because it's going to look upwards. I just get kind of a general sense of what's happening. Yeah. I don't think you need to know all these words.
Yeah, so these are straight from the textbook. As I said, this is a very low yield type of question. the ones I was just going to go through here, the higher the ones, these you do have to know the muscles actions.
Yeah.
Because they are clinically relevant. There's going to be tests that require you to do them. And if you see here, for example, deltoid is, really quickly, it's AB abduction from 15 to 90 degrees. Now, abduction from 90 to 90 further is actually a different muscle, right? So you need to know the differences just because they might ask you questions on that. So that one before, not really, you just have to know the general one, as David said. For this intrinsic shoulder muscles, definitely need to know the muscle actions, and most likely at least the degrees as well. Okay. Yeah, so the ones highlighted are rotator cuff muscles, so the sits, as we talked about. And again, the only exception of the rotator cuff muscle, every one of them are attached to the greater tubercle except the subscapularis. Okay. Now, innervation as well, it's relatively simple to memorize if you can. I found it relatively simple to memorize because there are some trends in it. Supra, infra, both spinatus gets suprascapular nerves, and then the teres minor is axillary, and subscapularis, subscapular nerves. Deltoid is also axillary nerve. Now, you do need to know the nerves, just because if they get damaged, they will definitely have an impact on these muscles, right? Because they're being innervated. So you do need to know what muscles are innervated by what. Did you want to say something, Dave?
Yeah, I got a point, and then also someone asked the question. So another reason why we'll try to bring it together now is if you look at the axillary nerve here, you have your deltoid and your teres minor. If you remember, we talked about a fracture to the surgical neck of the humerus. That is a beautiful humerus. So if you have a fracture here, the axillary nerve actually runs by there. So then you can expect for the teres minor and the deltoid to be affected, which means you'd expect they wouldn't be able to abduct from 15 to 90 degrees. Whereas if you find they can't start abduction, but once they've gotten to 50 degrees, they can keep going, then that's probably something wrong with your rotator cuff muscles or your supraspinatus, 15 degrees. Peter, did you use Anki to learn these?
At the end, I did, yes.
So would you suggest that we make our own anatomy Anki decks or just use pre-existing decks?
Okay, so I've always been of the mind that you make your own notes, you make your own Anki cards. That's just been me. I've talked to a lot of seniors that say just use the ones that's pre-made. I've talked to people that say they found it useful when they make it themselves. I personally think it's a personal thing. Like, I feel like it's whatever suits you better. Personally, the reason why I make my own Anki cards is actually I don't make my notes anymore now. I made it in year 1. I stopped making them in year 2. And I basically just make Anki cards. So because I do that, I kind of learn as I do it at the same time, if that kind of makes sense. So that's why I personally make my own Anki cards. But I could see why a lot of people would choose to just use the Anki cards that's made, because you might feel like you're adding irrelevant stuff. You're adding more stuff than you probably won't, that you don't need. And if you find a deck that's been proven over the years, you can just rely on that. But I just feel like sometimes the question format and the answers might not be to your liking. So instead of editing everything, I'll just find it better just making it for myself. So yeah.
Yeah. Okay, a couple more questions. Just on that, I would use a pre-existing one because I just would stop doing it if I made my own. Someone asked what type of Anki deck's out there. There's something called the Cranky deck. I'm happy to send it to anyone who's interested. Daniel asked me the question, I'll send it to Daniel. Yeah, so that's a one they used some of the professors to help them make it, so it's pretty reliable. Someone said, yeah, sure. What I'll do is I'll post it on the PS Peppa Pig page. Someone asked, can you please write out what you said about the angles and fractures surgical neck? There's about...
Okay, sorry. Yeah, that's just one point. I believe the fractures of humerus is next week. That's what it says in the prac book. So I put those slides for next week. There will be slides on it, but yes, you can talk about it later. Just letting you guys know as well.
I'll do it quickly. This is your surgical neck.
So I'll just go to the
that would be helpful.
Yeah.
Here we go. Okay, I'll tell you all of this information. Sorry, I made a mistake. I'm back. This is the surgical neck. The axillary nerve runs through here. You know that the axillary nerve innervates the deltoid muscle and the teres minor. So if there's a fracture to the surgical neck, the complication can be to the axillary nerve, And as a result, they won't be able to abduct their hand very far up, past 15 to 90 degrees. You can have a shaft fracture. The brachial artery and radial nerve run in the spiral groove. That's often affected. So think of radial nerve, shaft fracture, axillary nerve, surgical neck. And this is an ulnar process over here. If there's a fracture here, the ulnar nerve is often affected, it goes posteriorly. We'll do that more next week. If you're pretty good if you know surgical neck, axillary nerve, shaft, radial nerve. That's on the exam. They actually don't go in much more detail than that.
Yeah. This applies a bit more for next week, but just do know that because the nerve continues to go down, like if you get an injury at a certain point, the ones above it haven't been injured technically because the start is still in the brachial plexus in the upper limb mostly. So always keep that in mind. Just because axillary nerve is damaged doesn't mean that every function or every muscle that it innervates is damaged. You have to see where the location of the damage is. Okay, and that's why you should know where the muscles are in relation to the compartments because it will help you memorize it instead of just yeah. Anyway, yes, so that's really good. So teres minor, major, and deltoid also part of it. And if you look at the images here, so this is the rotator cuff muscles like sits. That's how they use the four fingers there around the humerus. That's the humerus right there, the left humerus. So you can see how the S here, the one that is only attaching to the lesser tubercle, the subscapularis, sits over here, whereas the other three muscles sit on the greater tubercle over here. Okay, so this is really how they kind of attach to the humerus. And you can see the intertubercular solace or the bicipital groove that we also talked about. Yes, and this is just also how the muscles look in relation to the other muscles in the forearm or in the shoulder as well. This is the deltoid muscle right here. Pec major, obviously deep to that with pec minor over here. Latissimus dorsi we also talked about. These we'll talk about a bit later. Yes, and this is just another nice diagram showing the different muscles.
Peter, can we go back a slide?
Yeah.
Just because this is important, I'll re-emphasize it. The reason why subscapularis goes on the lesser tubercle over here is you can see over here, it's on the anterior aspect of the scapula. So it's the action of the subscapularis is a different action, is the antagonist to the other three muscles. So it's internal rotation, which is like that, which is the opposite to the other ones that pull backwards. So if we go back to that other slide, thanks, Peter. You can see supraspinatus, supra on top of, infra below, infraspinatus, teres minor is on the lateral end over here. So these all attach to the same place because they have the same action from the same origin. If you need to know anything, rotator cuff is the most clinically relevant thing we're saying today.
Very important, which is why I have another clinical on the slide. Rotator cuff tendinopathy, which is just basically inflammation of tendons of the rotator cuff muscles. And the cause of this is normally repetitive use of shoulder joint, for example, swimming. And over time, so the tendinitis also could lead to bursitis and impingement, which will be called the swimmer's shoulder. The muscles affected most commonly is the supraspinatus. And that's just because of the fact that if you look here, it does the abduction from 15 degrees and also assists abduction, and the fact that it's on top, I believe, it's just basically impinged more often, the tendons. And basically it rubs against the coracoacromial arch, which will lead to inflammation and degenerative changes in the tendon if not treated. And this is a very important thing. The test to see if they have it is they basically ask the patient to abduct their arm, and the positive test, so the fact that they will have the rotator cuff tendinopathy, will be pain between 60 to 120 degrees, which is called a painful arc. Okay.
Yeah. And
yeah, that's right. Yeah.
Just with that, the reason why it's 60 to 120 degrees and why that seems like a random number is this is our supraspinatus. It is the highest muscle. This is our coracoid ligament, coracoid process acromion. you can see at about 60 degrees, this is going to catch on that, and that's going to cause pain. Is it 60 degrees from when the arm is down? Yep, 60 degrees relative to anatomical position, which is arms by your side, palms facing up.
Yep.
So it's 60 degrees just because of this interaction.
Yeah. So
And
I
it's
believe like,
approximate.
yeah, I was gonna say, it's basically approximate. It's not like you get a protractor out and be like, is this exactly 60 degrees? Just a broad estimate. The treatment for it is rest, anesthesia, or physiotherapy. If you're serious, you can get some steroid injections and surgery. Okay, so extra notes. These are some extra notes that I found that were useful, but just didn't really find any space on my other tables. So pectoralis major is a large fan-shaped muscle, and it covers, as we talked about, the superior part. It covers the superior part of the thorax, and it is again superficial to the pectoralis minor. It consists of clavicular heads and sternocostal heads. And the reason why this is kind of important is because they have different functions. So if they work together, they do add the adduction and medial rotation of the arm. But if they work independently, the clavicular head flexes the humerus, whereas the sternocostal head extends it back from the flexed position. So like the pectoral major basically has its own antagonist in a way. But obviously, the flexion of the humerus is just by the pec muscle. So yes, and pectoral minor is covered entirely by the pec major, and it's much smaller than pec major, as we saw before in the image. A deltoid is thick, powerful. It also covers the shoulder. It's shaped like a delta, which is why I think that they call it deltoid. It also has 3 heads, anterior, lateral, and posterior. This is important because I have this thing here, which is the movement of the shoulder joint and the muscles involved. You will see that there's different deltoid that's referred here, posterior deltoid. So I'm not quite sure how important it is. I find that they did have it in the notes, so I did write it down. Teres major is more superficial, as we said. So teres major is something we haven't talked about, but it's more superficial and inferior to this teres minor. So this is kind of like a common theme, minor and major muscles. The major is mostly more bigger, and they are normally superficial. Teres minor muscle is also smaller because it's minor. It's a thick rounded muscle. Rotator cuff muscle. So this is pretty important. The resting tendency of a rotator cuff muscle is to pull the head of the humerus into the glenofossa. So therefore, it will help with this reinforcement of the joint and, in a way, the stability of the joint. Okay. So that's why rotator cuff muscles are very important to your body as well. So some really quick questions. What movement would this be of the shoulder joint? I won't spend too much time on this. Give you like 5 seconds. But in these two as well.
So if you want some help with this, what is it the opposite of in these images? So you'd think, well, it looks like it's in the same plane as this movement.
Mm-hmm.
So therefore, what is it?
Yes, so I think someone answered this, so I'll quickly go through it. Extension, shoulder extension, because it's the opposite of flexion. And this is adduction, getting it towards the body, abduction, going away. Now, this thing right here, it is important to know, I think. You do need to know that, as we said, extension, flexion, you can see the degree differences. That's just because flexion just occurs more naturally, extension doesn't. Okay, I just want to quickly go through. So I'm going to quickly skip this. And now I just really want to go through at least this for today, and maybe just get you guys to read the other ones because there's a lot of it. Sorry. So sorry for having so much, but that's just anatomy, really. So brachial plexus is very important. Brachial, it means arm. Plexus means mixing of nerves. Therefore, brachial plexus means a mixing or the network of our nerves that send signals from the spinal cord to the arm. Okay, spinal cord to the arm. We use this term innervate when referring to nerve sending signals to a place, or basically innervating them. Begins in the root of the neck and it goes to the axilla, and then it goes to the upper extremity of the upper limbs. So this is a very simple diagram that you should probably get started with if you haven't seen brachial plexus before. They have 5 different, I don't know what you want to call them, divisions, but then there's divisions here. Basically 5 different things here, columns. Their roots, trunks, divisions, cores, and branches. This is a mnemonic that I used. Rugby teams drink cold beer. called via. And MARMU is just the end nerves, MARMU. And basically, the roots is referring to the spinal cord. Oh, sorry, David, did you want to say something? Okay, yeah. So this is the spinal cord. So I haven't gone through exactly how they're named, but basically C is cervical. So C1, C2, C3, C4, C5, C6, C7, C8 is the end. And then there's T1, which is this new spine. But basically, this is spinal roots. So they will send these their roots, and then they'll form 3 different trunks. So superior, middle, and inferior. Okay. So if up here it's pretty clear, it's pretty easy. Then it kind of gets all messy, goes like all over the place. Okay. I try to color code it as much as I could, but you can see how the posterior part receives all nerves from superior, middle, and inferior. So did you want to say something, David?
Yeah. So someone asked, is C5, etc. a nerve? They are nerve roots. So they come from the spinal cord. They're called nerve roots. These are sorry, I'm not annotating. They come from the spinal cord. These are nerve roots purely on that level of the spinal cord. They are different to these nerves because these nerves are constituted of a combination. So these combine, and together they make these nerves. So C5 is a nerve, but it's a nerve root. It's quite big. It can be the ventral ramar usually.
Yes.
Good question.
Yeah, don't worry too much about the root part of the upper limb yet, because you will have a separate lecture on how the cervical roots and stuff like that work. All you need to know is that these are the 5 different roots that occur at that are part of the brachial plexus, and then the trunks, and then divisions, and then the cause, and then the branch. So these divisions, you might be like, how the hell do I memorize at the start? I found it useful to draw it out early on. Next slide, I do have a really good link to this video that I found really useful. Help draw the brachial plexus. If you watch that video, it's very fantastic. It's like 3 minutes long as well, very short. So I won't go into too much detail about how to draw it. Just one thing I wanted to talk about is the cords here. These cords, all of a sudden, they're lateral, posterior, and medial. So you might be asking, these are anatomical terms, so what do they refer to? Because, for example, the trunks make sense, superior, middle, and inferior, right? These are just lateral, posterior, medial. Well, as I wrote here, the cords lie in relation to the axillary artery. So you realize the axillary artery actually kind of also comes across through the brachial plexus, with the brachial plexus. And basically, the posterior part will have the cords posterior to the axillary artery, and lateral will be in relation to the artery, and medial in terms of the artery as well. Now, just one thing, even though this diagram looks like it's straight, you have to remember that it's going down the arm. So once it goes down the arm, it comes from becoming from superior, middle, inferior to medial, lateral, and posterior, because it's going down the arm now. Okay. Now, the branches are also very important for you to know. These are all the main, you definitely need to know these nerves for upper limb, for sure. If you only need to know 5, you definitely need to know these. And as you can see, muscular cutaneous nerve, for example, C5, C6 go all the way through to the branch of muscular cutaneous, but also C7, because it joins in the division, goes to the lateral cord. So now you can see that it's C5, C6, C7, okay? And axillary, similar, except it only accepts C5 and C6. So it's not actually the C7 and C8 and T1 that it looks like in this diagram. Although radial is all, I think. Yes, radial is all. So yeah, consumes every one of them. Ulnar nerve is just C8, T1. So it's one of those nerves to go straight through. As you can see, only the inferior trunks basically transfer to the medial cord. One thing that's really important for you to know is the median nerve has a characteristic of an M shape. If you can kind of see that M shape here, like an M shape here. And that's important because in specimens, you'll realize sometimes you might need to identify certain nerves. They might get you to ask, they might ask you, oh, which one is the axillary nerve? Well, which one's the median nerve? Then you try to figure out at least the point of reference, which will be the median nerve, because it's easier to figure out because of that characteristic M shape.
And there's other
Yes, sir.
Yeah, I was going to say there's other buzzwordy things like that, like the musculocutaneous nerves pierces the coracobrachialis muscle. So if you see any fiber piercing coracobrachius, that's musculocutaneous, and you can orientate it like that. Yeah, I'd learned.
Yeah. Because if you see a specimen picture, you'll be like, that does not look like what I learned in my textbook. It does not look like it does not look at it like it just looks completely different. So you need to know these reference points for you to really understand what's happening. For this whole diagram, I ended up just putting the whole diagram in my Anki and just covered up the ones and memorized it. That's how I memorized it. I think some people just kind of memorize it a bit differently. The main important thing is the bottom part here. These are some really nice actual information of it. And I realized in the prac book, they kind of emphasize brachial plexus a little bit. So have a look at those as well. And you can see there's different branches that come off as well. You do need to know some of them, like for example, the thoracic, which goes to serratus anterior. If that gets impacted or damaged, then the long serratus anterior will be damaged, which will mean winging of the scapula. So buzzwordy words. So you do need to know some of these for sure and what they supply. So a lot of memorization here, but I think you get through it. Again, as I said, that's a nice diagram and nice video there. This is our table that I had. So if you can see, we talked about, I think it was not quite sure who asked me the question, but they said, what exceptions do we need to know for the nerves? Well, this is a very good example right here. The musculocutaneous nerve supplies all the muscles in the anterior compartment of the arm. So that's the general rule. That's all about it. And then the median nerve here, don't need to know any of these muscles or any of these right now. But all you need to know is that they have all muscles, they supply all muscles in the anterior compartment of the forearm except the flexor carpi ulnaris and medial half of the flexor digitorum profundus, because this is innervated by the ulnar nerve. So these exceptions you need to know because they will ask you, they will try to target these nerves and be like, you might be like, oh, the general rule is that the median nerve supplies all the anterior compartment. Oh, that's an anterior compartment muscle. Oh, it has to be supplied by the median nerve, but it isn't. And good thing that you realized the relationship between median nerve and anterior compartment of the forearm if you did that, but you do also need to know the exceptions because they will ask you. So this is a relatively high, very high yield actually slide because you don't need to know all of it. Actually, you probably do need to know it. I didn't write too much on it, to be honest. So that's really important. Also, another one is axillary nerve. Once it provides sensory to the regimental badge, is shoulder area. I believe it's like here. So a very common thing is like numbness on the regimental badge indicates axillary nerve damage. The course of the nerves is pretty low yield, but I did have a link here to the notes that I made last year if you want to look at it in detail. It does help understanding how the nerves travel, but I found that it's more easier when you learn the muscles of the forearm kind of naturally comes as well. Yes.
Yeah. I'd strongly recommend looking at that.
Okay.
Because it
The
helps.
previous BSV said don't need to know about it as in low yield, but they did write it, so I also wrote it down. Yeah, it also helped me as well, but I didn't have it in the slides.
Yeah.
Dermatomes and myotomes. Dermatomes are an area of skin that is supplied by a single spinal nerve root. Okay, they are not the same as cutaneous innervation, which is basically nerves, so the nerve branches, whereas the dermatomes are due to the spinal cord roots, so C1 as well, not C1 in this case, but C5, C6, all of the ones that we just talked about in the brachial plexus. And this right here is myotomes, okay? And those are groups of muscles supplied by a single spinal root, nerve root, sorry. So it's very similar. Dermatomes are skin, myotomes are muscles. You do need to know the dermatomes. Now, there was a really common thing that we used to be asked, or people used to ask is, how do we know exactly where the T1 ends? Or how do we know exactly where the C8 innervates? Because this diagram and all diagrams are very different. And the faculty just said, there's differences, individual differences. So don't worry too much about understanding exactly where the endpoints of certain nerves are. Just understand where they really are situated. Like just know that T1 isn't over here, right? The C4 isn't over here. Just need to know the general gist of it, more so than understanding exactly which muscle, which part of the body it stops in terms of the dermatomes. Okay, so that's skin. And myotomes are also very important to know. I just put that in my Anki and just learned it. C5, C6 shoulder AB duction, C6, C7, C8 shoulder AD duction, because they are supplying the nerves of the muscles that are responsible for this. But it's relatively easy. You can see this little pattern: shoulder, shoulder, elbow, elbow, wrist, wrist, finger, finger. And that's also a common theme here in the dermatomes. C4, 5, 6, 7, 8, T1. It kind of goes around in a loop. And this is just a general thing in spinal nerve roots, it supplies whatever is nearby. So if it's in the cervical area, it'll supply the ones near the cervical area. If it's in the lumbar area, supply the areas near the lumbar. That's just how it works, except there are differences, which you'll learn in year 2, actually. So you don't need to know too much about that.
Got a question.
Yes.
Confused about the term single spinal nerve root. Isn't there a lot of overlap? Is only one nerve root really supplying that area? So it depends what you're talking about. It's a good question. It's not a stupid question. So it's the reason why it's an important question is that's why we learn this essentially. In other words, if someone is presenting with, I have numbness, as a clinician, you don't know where to start. So if they say I only have numbness in around this area, and maybe they describe it overlaps here a little bit or it overlaps here a little bit, you know, maybe I'm looking at a nerve root problem, because in reality, during embryology, the nerve roots are what supply everything of that level. So you can see T8 here. The only reason why these look weird is because of the limb buds. But in actuality, the dermatome or the sensory innervation is only innervated by one nerve root. In practice, there is a significant amount of overlap, and you have to be considerate of that, but it isn't going to be as complicated as if it was the median nerve, which does the anterior forearm and could completely mess this up to a point. And then some of it is ulnar as well, but that's not the point. That's also why you test myotomes as well. You have both of these because you're right, it can be quite non-specific. There can be quite a lot of overlap, but they are, in theory, this sensory area is that information is carried back to the nerve root.
Yeah.
However, maybe through whatever nerve that is there. Yes. Whereas the muscles of this point are supplied by here. Does that make sense?
Yes.
I think that confuses a lot of people, so it's a good question. I remember being confused by that as well.
Yeah. So this is just a table showing exactly technically where they are located. But as we said, don't get too involved in noting that there's differences with different textbooks. Okay, I will just quickly skip that. Just lastly, I just want to go through Axilla and I'll leave everything else. This is very important because they wrote a lot on your prac book. So the Axilla is something that looks kind of like this. I don't think I have an image. Oh, I did. Oh, there it is. Okay, that's weird. So it's located right here. So the first rib, the clavicles here, the humerus, the glenoid fossa we talked about before. That's the axilla right there. Okay. And as you can see, there's boundaries to it, right? Because there'll be things overlapping, things like that. So because of that, you do need to know the boundaries. You do need to know what's happening, especially because they're written right in your prac book, but it is relatively low yield. Okay, they don't ask you too many questions on it. Just need to know that there's contents within the axillary region. These are all of it. I'll read that. I'll let you guys read that for yourself. And lymph nodes. So they actually had an emphasis on lymph nodes this year. So I'll quickly go through it. There's 3 main ones here: pectoral, subscapular, humeral. They all travel to the central nodes, and then these travel to the apical nodes. Okay. You can read the actual ones in detail a bit later. And the reason why I just wrote those 3 is because this is relevant to the clinically, because there could be infection of axillary lymph nodes. So an infection in the upper limb could lead to an enlargement of axillary nodes and therefore lymphangitis. And the humeral nodes in this case will be involved first. So you could check for humeral nodes. More importantly is breast cancer. So localized breast cancer have no lymph node involvement, but when there is lymph node involvement, it's locally advanced breast cancer because the lymph receives the metastatic breast cancer cells. Because of the fact that I just told you guys that these 3 go into draining into this 3 and then to here, we can check the progress and the stage of the cancer development if we check the lymph nodes and see how many cancer cells or how inflamed they may be. Okay, and during the surgery, so this is when we take out the axillary nodes, there's 2 nerves at potential risk. The long thoracic nerve we talked about to the serratus anterior, again, damage will lead to winged scapula, and thoracodorsal nerve to latissimus dorsi. If you remember, the medial rotation adduction is what the latissimus dorsi does, that this will possibly damage that as well. Okay, and if the nodes are are around these nerves are too swollen, they will need to sacrifice these nerves to stop the progression of breast cancer. Okay. Now I will just skip all of this. This arterial thing is pretty important because I know it says relatively low yield, but it was written in your prac book, so they definitely could ask you questions. And there was a question about how the axillary artery is divided up in your prac book. If you want some answers, there they are. And venous to drainage, just a common thing. Arteries and veins kind of come together, so they're kind of all in the same place. So veins have the same name as arteries, basically.
Yeah. I'll just say one thing, because that was on a couple of exams I remember practicing for. Can we go to that like the pec minor dividing them? So a common question will be understanding that the pectoralis minor is what segments this axillary artery from its into these different divisions. And yeah, I think that's important to know. That could be on an exam.
Yes.
Would recommend reading through these, even like superior thoracic artery coming off the first segment. Like this is quite helpful to know. There's not going to be more than 1 or 2 questions, but yeah, I'd recommend going through this.
Yes.
In your own time.
Okay. And that's it. Physiology. David, if you want to cover what's
I'm going to do this
for...
as quickly as humanly possible because I'm tired too. I'm going to share my screen. We're going to do this in 5 minutes. Let's have a look. Peter, do you mind if I share just so I can click through quickly? Okay. We're talking about physiology today. This is quite low yield, all of it. Motor control is talking about how there's a dynamic interaction between the internal body and the environment. You sense the environment, it's integrated into your brain where that information is processed so you can have a motor output and a reaction. When it goes to your brain, you have different cortexes that interact with each other in order to coordinate, plan, and execute movement, and they eventually generate nerve signals that execute movement. An important feature to know is the primary motor cortex or precentral gyrus, which is at the posterior end of the frontal lobe. It's important in the execution of movement. This is just showing how signals are integrated. Information is sent from the environment, integrated and processed in the brain, and sent to the spinal cord to activate efferent fibers. Eventually, the cerebral cortex will go to the brainstem to the spinal cord to activate. There's different processes that are modulated. So the cerebellum facilitates for smooth movement by controlling time and a sequencing of actions by comparing to the internal environment. This talks to other features of the brain, such as the cortex, which is higher functioning thoughts, plans, and perceptions. All you need to understand here is there's a complicated process of dynamic actions occurring in the brain to allow people to have movement. There's 2 types of nerves that can conduct signals. Sensory nerves include visceral sensories that conduct impulses from organs or internal stuff, and somatic efferents that are often from skin, skeletal muscles, and joints. So somatic is things that often interact with things and need to be quite sensitive. Visceral are stuff like your diaphragm that shouldn't really be interacting with the outside world. So it has a different sort of sensory afferent that doesn't need to be as detailed as a somatic one. Motor efferent somatic is voluntary skeletal control. Autonomic is involuntary. Parasympathetic, rest and digest. Sympathetic is oh my god, what's sympathetic? Sympathetic is flight or fight. That is scary because I cringe whenever people say that in every lecture, and then I just forgot it. Organization of the spinal cord. Afferent sensory fibers have their cell body in the dorsal root ganglion, and they often go up to the brain through ascending tracts. Efferent motor fibers go down through descending tracts. They synapse in the ventral horn and go through the ventral root. Sometimes there's an interneuron here that forms a reflex, in which case there wouldn't be descending or ascending tracts. A motor neuron often resides in the ventral region of the spinal cord. The ventral horn will be enlarged in areas that have lots of muscles that need to be used. So, for example, in the things that innervate the upper limb and lower limb are quite enlarged. The ventral horn in the medial section, so over here, innervates muscles proximal to the body. Distal section, muscles distal to the body. That's a cool thing to note, and I think that's quite important. If you stimulate particular areas, if I stimulate this proximal muscle area, I'll target particular muscle groups. Alpha motor neurons are lower neurons that directly innervate muscle that are different to upper motor neurons. That is when the brain sends signals to the spinal cord. They can be voluntary and involuntary in reflexes, and they originate from the cell body of the ventral horn and go by the ventral root to terminate on the muscle fiber, and they release acetylcholine. I'm trying to go quicker. The motor unit is one alpha motor neuron and all the motor fibers it innervates. A motor neuron pool is all the motor neurons that innervate one muscle. So here you can see one alpha motor neuron innervating particular muscle fibers. Here it's one muscle and all of the motor neurons that do that. Small motor units, so if there's only one or two motor units here, that's involved in fine control, whereas larger ones are more powerful and you have less fine control. Almost done. To generate more force, you can stimulate it more at a higher frequency, or you can have more things stimulated. I'm not going to read all of this. I'm going to just give you the gist of it. If you want to have a lot of force, you want to have a lot of stimulation, as opposed if you have low force, you have time for it to recharge and it doesn't get back. Whereas here, you're stimulating it while it's before it's relaxed. So that's why it gets higher. If you stimulate it a lot, it becomes fused tetanus. That means the muscles are not going to relax. Whereas here there's oscillation. The reason why often you'll have single muscles oscillate is it often balances itself out because you have a lot of muscles oscillating in different directions. The more you stimulate, the more likely you're to get tetanization, which is the smoothing out, and you're going to have a sustained forceful contraction. Size principle is that smaller motor units with precise control, which are slow and fatigue resistant, so they're more sustainable. They will be recruited first, whereas larger motor neurons have a higher threshold because their cell bodies provide more resistance. So you're going to need more current or more electrical stimulation in order to recruit them. These are fast fatiguing fibers. They have a lot of power, but they get tired really quickly. So you're graded in your recruitment according to cell body size. If you want to pick up an egg, you need fine motor control. With a small motor unit, you want a slow firing rate for a little bit of force, but for fine control, and it's going to be fatigue resistant. Whereas if you want to crush it, you want to stimulate lots of motor units of high firing rates to be very forceful, use lots of fibers, and you might even resist if you're really strong. This is what skeletal muscle is, which is revision from last year, which I don't think we need to go over. Thoughts on going?
Let's skip it because it's beautiful slides. You can read it and you understand everything.
Yeah, and Kat has made these notes and they're perfectly self-explanatory.
Yes.
Thanks everyone for being with us.